Hello and welcome everyone. We are going to be talking about a case study regarding diabetic ketoacidosis, and this leadership project was created by Katie, Bojana, and Karen.
The first thing we're going to talk about is an SBAR report. SBAR stands for Situation, Background, Assessment, and Recommendation. Now, some journals have an I at the beginning and a Q at the end. That'll stand for an introduction. So that's if I call a physician and I say, "Hi, my name is Katie. I'm the RN taking care of your patient in room 26. It gives the who are you and who are you calling about. And then at the end is the Q, questions and answers. This will allow for the other person who you're giving the report to ask any other questions that could help them get a well understanding of the patient's care. But for this situation, we're just going to go with SBAR. It is a communication technique that allows for a thorough handoff from nurse to nurse or from nurse to physician, and it really gives you a good understanding of this patient's care, why they came in, what their background is, what is their current assessment, and what should we do in order to continue this care effectively. So it's also really, really helpful in emergent situations. Let's say you call code blue on a patient. You're going to have nurses, pharmacists, physicians, respiratory therapists coming to your room. This communication allows for a quick and concise report to these to these other healthcare workers, so they know the best way to go about the care for the patient and resuscitate them. The first part of an SBAR is situation. So this is going to contain a couple different areas. It's going to do the patient age and gender, the complaint that the patient was having, the diagnosis, the treatment plan, and any patient's wants or needs. So for our case study, this is how it would go. Mr. Lopez is a 78-year-old male weighing 315 pounds. He was found with an altermentation and fruity odor coming from his breath following a right total knee replacement. He is being treated for DKA due to a blood glucose of 468 and a present ketones in his urine. Currently, he is on normal saline running at 500 milliliters an hour for fluid resuscitation and regular insulin drip starting at 0.1 milligrams per kilogram per hour. Next is the background. This will include any vital signs, mental status, code status, list of medications, recent lab results. You can also put in some allergies and also medical history. For this case study, it would go like this. The patient states that he has been managing his type 2 diabetes for 43 years with blood glucose readings when he feels different and taking Humulin R on a sliding scale. He is also being diagnosed with osteoarthritis, which has led to the current knee replacement. His vital signs were a heart rate of 100, respiratory rate of 32, blood pressure of 116/78. His lab results were a sodium of 135, potassium of 3.2, chloride of 95, and calcium of 8.5. The physician also ordered an ABG with the results of a pH of 7.31, a PCO2 of 20, a PO2 of 95, and a bicarb of 12. Then we have the assessment portion. This is the current caregiver's assessment of the situation. So if you're the nurse, you have just done an assessment. This is what you've seen last on the patient, and this is what you're going to hand off to either the new nurse or the physician before you ask for a recommendation. So for this case study, it would go like this. An hour after his insulin was started, I went in and reassessed, and his blood glucose level had dropped to 208. He appears more comfortable. His current vital signs are a heart rate of 92, respiratory rate of 22, blood pressure of 116/70, and an O2 is 95% on 2 liters. He is somnolent but arousable and alert and oriented. Lastly, you have the recommendation. This is when you identify any pending lab results, diagnostic procedures, and what you think the next few hours of care should be. So when you're giving report to a new nurse, this is the first time they might be encountering this patient, and you've had them for the past 12 hours. So the recommendation is incredibly important. And for this case study, it would go like this. The next part of his care will consist of blood glucose checks and might need to be started on D5W if his levels drop too fast. His potassium needs to be monitored. It was at 3.2 and might need a potassium replacement. The goal is for discharge with an order of gabapentin. He will need education on diabetes management, drug administration for the gabapentin.
Diabetic ketoacidosis. What is it? On a pathophysiological level, it is a life-threatening condition due to a metabolic emergency within the body. This means that the insulin levels are critically low, which prevents glucose from entering the cells. Without glucose, cells respond by acting as if they are starved. Because the body acts this way, hormones such as catecholamines, glycogen, growth hormones, and cortisol counteract this. The liver releases glycogen to create glucose in addition to using stored fat for energy. This action produces ketone acid byproduct that can lead to hyperlipidemia and metabolic acidosis. Metabolic acidosis causes hyperventilation and Kussmaul's respirations as a compensatory mechanism against this. The kidneys diurese to remove excess glucose within the body. The kidneys will also remove water and electrolytes, which can cause dehydration and an imbalance of these electrolytes. An imbalance to these electrolytes and dehydration will cause cardiac dysrhythmias and can potentially cause a coma. DKA mainly occurs in patients with diabetes mellitus type 1, but can also affect patients with diabetes mellitus type 2. In our current case study, the patient has a history of diabetes mellitus type 2. Some age considerations for patients with DKA is that 14% of cases occur in patients over the age of 70, and the mortality rate is as high as 10%. Some major risk factors specifically for this patient in the case study is trauma or any severe medical illness. Next, we're going to be talking about the different signs and symptoms that are manifested with patients in DKA. Some early signs include polyuria, polydipsia, nausea, emesis, abdominal pain, change in appetite, weakness and malaise, sudden weight loss, blurred vision, headache, drowsiness, fruity breath odor, dry mucous membranes, tachycardia, hypotension, and hypothermia. Some more progressive signs of DKA are Kussmaul's respirations and potential comas. To the right, we have a short little video showing Kussmaul's respirations in a patient. Now we're going to be talking about some different treatments for DKA. Nurses will administer insulin, more specifically regular insulin. The onset is 30 minutes to 1 hour. The peak is 2 to 4 hours. The duration is 6 to 8 hours. Nurses will also administer intravenous fluids. Of course, this is per hospital protocol, but typically it'll be 0.9% normal saline first, and then can be progressed to 0.45%. Dextrose 5% in water can then be used, and bicarbonate may be ordered in some rarer cases. Nurses will also administer potassium. Administration of potassium can be provided even when the level is within normal range of 3.5 to 5. This is because the level may drop quickly when fluids and insulin are administered. Administration of phosphates, magnesium, and calcium can also be provided due to a potential imbalance in electrolytes. Nurses will also monitor labs to note any trends and abnormalities. Normal lab findings for DKA is that glucose will be greater than 250 milligrams per deciliter. They'll have elevated serum ketones. Bicarb levels will be less or equal to 15 equivalents per liter and an anion gap of greater than 10. Arterial blood gases will also show a pH of less than 7.3, and urinalysis will show ketones and glucose. Metabolic panels should be drawn every 2 to 4 hours or per hospital protocol. Nurses will also monitor heart rhythms for dysrhythmias. EKGs will typically show sinus tachycardia in addition to any arrhythmias. Nurses should also assess neurological status for signs and symptoms of cerebral edema. In addition to this, nurses will also monitor intake and output for signs of fluid overload or current dehydration status. Finally, nurses will also assess kidney function due to needed excretion of fluids and diuresis.
Based on the case study patient's cultural and spiritual background, the nurse can tailor the care based on their needs. First, looking at the cultural aspect, it's always important to build a therapeutic relationship with the patient in order to gain their trust. Then it's important to consider any language barriers, using translation lines as needed. Next, we would want to consider the patient's diet. Diet considerations are essential when caring for the cultured patient. So we would include any personalized meal plans that are tailored both to the diabetic diet and the cultural preferences. According to the CDC, Hispanics come from a collectivistic culture, which means most of the responsibility is shared between family members. With this in mind, the nurse would respect the patient's need for increased family visitation as well as involving the family in the plan of care and education. Next, understanding the patient's views on their illness is an important component. The CDC mentions that in Hispanic cultures, getting a disease is actually a bigger concern than dying. Now, when looking at the spiritual considerations for this particular patient, it was implied that the patient and the family were Catholic and also participated in the religious rituals. Research actually shows that spiritual commitment tends to enhance recovery from illness. Things that the nurse can do to support the patient's spiritual needs include things like praying, reading scriptures, and offering spiritual services like chaplains. The patient should be educated on their new order for gabapentin to include both verbal education and written instructions that they can take home. The nurse should educate the patient on the indication for the drug, which in this case is for neuropathic pain. It's important to teach the patient to take the medication at the same times daily and to never abruptly stop the medication. Educating the patient about possible side effects is also important. According to the Davis Drug Guide, dizziness and drowsiness are common side effects. With that in mind, it's really important to teach the patient and the family about safety precautions. The priority nursing diagnosis is deficient fluid volume related to hyperglycemia-induced osmotic diuresis, as evidenced by a blood glucose of 488, increased urinary output with ketone bodies present, increased thirst, heart rate of 100, and metabolic acidosis with partial compensation. For the short-term expected outcome that is listed, one of the first interventions that the nurse can do is to monitor the patient's response to the prescribed fluid therapy by assessing their vital signs every 4 hours throughout their shift. The second intervention includes monitoring total fluid intake and output throughout the shift. Lastly, it's important for the nurse to monitor the older patient for excessive fluid volume during the treatment. And they can do this by auscultating the lungs, monitoring labs, and assessing the patient for edema. For the long-term expected outcome that is listed, the first intervention is to assess the patient's current knowledge base about their diagnosis. The second intervention is to provide different learning materials for the patient, such as paper, demonstration, and even video. Lastly, the nurse should educate the patient and the family throughout the patient's entire hospital stay, to include teaching about appropriate diet and fluid intake, signs of deficient fluid volume in older adults, and also when to notify the healthcare provider.
And here's our references. Thanks so much for watching!